Peripheral nerves. Clinical clues in the diagnosis of focal peripheral nerve disease. Upper extremity. With marked differences in strength between biceps and brachioradialis, think of 1. A lesion of the lateral cord or musculocutaneous nerve. 2. A lesion of the posterior cord or radial nerve. With marked differences in strength between biceps and deltoid, think of the following. A lesion of the lateral cord or musculocutaneous nerve. 2. A lesion of the posterior cord or axillary nerve. The median nerve sensory fiber to the hand passes via the upper brachialis plexus originating from the C6 root to the thumb, the C6 and C7 root to the index finger, and the C7 root to the middle finger. It is not possible to differentiate C8 from T1 radiculopathy because all intrinsic muscles of the hand are innervated by C8 and T1 roots. With an ulnar nerve lesion of the arm, elbow, or upper forearm, sensory loss usually involves palmar and dorsal aspects of the little and ring fingers. With an ulnar nerve lesion of the distal forearm or wrist, sensory loss involves only the palmar aspect of these fingers due to the sparing of the dorsal ulnar sensory branch that arises from 6 to 7 centimeters above the wrist. With ulnar neuropathy, sensory loss should not ascend above the wrist. With C8-T1 radiculopathy or lower trunk plexopathy, sensory loss can ascend to the entire medial aspect of the upper limb following the distribution of the medial cutaneous nerves of the forearm and arm, both arising from the lower trunk. With weakness and or atrophy of the thenar and hypothenar eminences, think of C8 to T1 radiculopathy. 2. A lower trunk brachial plexopathy. 3. Concomitant ulnar and median mononeuropathy, for example, carpal tunnel syndrome and ulnar neuropathy at the elbow. In the case, flexor pollicis longus should be intact. Flexor, or the distal phalanx of the thumb, located in the forearm and innervated by the anterior interosseous branch of the median nerve. If there is a suspicion of a lower trunk brachial plexopathy and or C8 to T1 radiculopathy, the presence of a second-order neuron Horner syndrome is supportive evidence. When evaluating wrist drop, correct the wrist angle to the neutral position before testing finger flexors and extensors. If the brachioradialis and triceps are spared, the lesion is an isolated posterior interosseous mononeuropathy. In such cases, there is no sensory loss. If only the triceps is spared, the radial nerve lesion is at the spiral groove. If the triceps is weak, the radial nerve lesion is at the axilla. If, in addition to the triceps, the deltoid is weak, the lesion is not radial nerve, but rather a posterior cord brachial plexopathy. In the case of scapular winging, the winging is caused by 1. Serratus anterior weakness. If there is considerable winging at rest, there is medial translocation of the scapula, that is vertebral border closer to the midline. The shoulder appears lower on the affected side, and winging is accentuated by forward flexion of the humerus. 2. Trapezius weakness if there is less winging at rest, there is lateral translocation of the scapula, the shoulder is definitely lower on the affected side, winging is decreased by forward flexion of the humerus, and winging is increased by abduction of the humerus. Lower extremity. The only L4 innervated muscle below the knee is tibialis anterior. L4 to 5, dorsiflexor of the ankle. When evaluating foot drop, complete or incomplete, testing inversion of the ankle, tibialis posterior, and flexion of the toes, flexor digitorum longus, is very important. These muscles are innervated by L5 and to a lesser extent S1, nerve roots via the tibial nerve. They are spared with perineal neuropathy, but are weak with L5 radiculopathy. Remember to correct the angle of the foot back to 90 degrees before testing eversion and inversion. It is not possible to differentiate L2 and L3 radiculopathy because quadriceps, iliopsoas, and adductor muscles are innervated by L2 and L3 roots. The testing of thigh adductors, L2 through 4, obturator nerve, is essential in differentiating pure femoral neuropathy from root or lumbar plexus involvement. Thigh adductors are not involved in femoral neuropathy. In proximal weakness of the lower extremities, compare quadriceps and thigh adductors with thigh abductors, gluteus medius. If the weakness is significantly different, think of a selective root plexus involvement rather than a myopathy. And those are peripheral nerves. Have a great day.